So we're talking about the tricuspid valve and the pulmonary valve, and I'm going to focus on tricuspid atresia and Ebstein's, and then from the pulmonary valve, I'm sticking to PIAVS. Briefly, I'm going to talk about a little bit of the background of them, really focusing on diagnosing them, and then a little bit on outcomes, and I'm going to try and use lots of examples because I think repetition, as I keep hearing today, is really the way to get better at this. I'm not going to talk about this very much, but just to say that we've certainly heard about the normal four-chamber view multiple times. Where it's important to me for diagnosing things like I'm going to talk about today is actually identifying what is on the right and what is on the left, and that changes depending upon whether the baby is vertex or breech, like we've been hearing. And also focusing on, I heard someone call this the crux of the heart, and that's really important for me, and I'll kind of mention that over as I go through this talk, of differentiating right side from left side. So starting with tricuspid atresia. You have a plate-like tricuspid valve. That's kind of the main thing, most common thing. Plate-like tricuspid valve. A ventricular septal defect is usually present, but not always. And then the pulmonary valve may be normal stenotic or atretic, but that's in the situation where the great vessels are normally related, as shown here in the picture. You can also have transposition of the great vessels, where the aorta is the one coming off the small ventricle, and in that situation you might have aortic stenosis or even downstream obstruction, and I'll show you that. So this is a path specimen with a cartoon sort of side by side showing that plate-like atresia and then this hypoplastic right ventricle, and here's the ventricular septal defect. This is fairly rare, less than 3% of congenital heart disease, and most of the time the vessels are normally related, the great vessels, so about 70% of the time. It's broken down into this classification system. We don't, or at least I don't, talk about type 1, type 2, and type 3. I sort of say exactly what I think it is, meaning that in type 1, I would say that it's tricuspid atresia with normally related great vessels. And then where this comes into play is if the septum is intact, oftentimes, or by default, you're going to have pulmonary atresia. If you have a small VSD, that means not a lot of flow is going from the left to the right, and then not a lot of flow going out to the lungs. So the pulmonary valve is small, so you have pulmonary stenosis. But if you have a big VSD, usually that means that there's normal growth of the pulmonary artery, and those patients sometimes do pretty well and don't require surgery immediately after birth. They may even be balanced. And so it's sort of funny talking to families about, well, there's a large VSD, but that's really good, like in this situation, because normally you're thinking if there's a hole, that's always bad. Not so with single ventricles. So for type 2 then, transposition of the great arteries is the key here, and the presence of the VSD, similar to the pulmonary valve, determines how big the aorta is and whether or not there's downstream obstruction. And then the last type, type 3, is sort of the more complex associated things like AV canals, truncus, double outlet right ventricle, as I'll show you. So here's a moving picture with sort of the normal four-chamber view and then a frozen up here. So you see this plate-like tricuspid valve, and here's that crux. So importantly, the spine is down here, sternum up, vertex, so this is the left, and I have one well-functioning mitral valve with only attachments here to the free wall, and then here's the ventricular septum, and there's the ventricular septal defect with a hypoplastic right ventricle. So this is a classic tricuspid atresia. This is another one. This time the baby is breech, so left is over here. Here's the normal appearing left ventricle, smooth-walled, mitral valve attachments only to the free wall here. Here's the crux of the heart. There's the ventricular septal defect. Here's the small right ventricle. So plate-like atresia again. This is the same patient just sweeping up, and that first vessel here branches pretty early, and then the second one is smaller. So here's the first one, and then coming off of this small chamber is this smaller one. So the aorta, in this case, these are transposed. The aorta is coming off the smaller right ventricle, and then the PA is coming off the left ventricle. So that was tricuspid atresia with transposition. Here's another one, plate-like tricuspid atresia. Here's the crux of the heart there. Here's that mitral valve, normal, large, even left ventricle with a really small ventricular septal defect leading to this hypoplastic chamber. And so when flow comes in, you see it all goes from right to left, and then some flow is coming through that VSD back to the right side. So this, again, classic tricuspid atresia. Tipping up, so deciding whether or not you have normally related or transposed. So here's that left ventricle, that's good size. Here's that pulmonary artery in this case, because there's early branching here. There's actually a small VSD there, real hypoplastic right ventricular chamber, and here's a small aortic valve, small ascending aorta. And that's the flow going through that VSD and up the aorta. And this patient had tricuspid atresia transposition with coarctation. My talk was done, but on Tuesday, this mom came in. So I added this. And what is really important here is, well, not important to you guys, but we have a new sonographer learning how to do fetal. And this was the first picture. And so I said, vertex, spine down, dextrocardia. And I kind of got excited. I'm like, oh my God, this is going to be heterotaxy, such a cool case. And about 50 images later, they switched. They had the marker on the wrong side. And so actually it was normal levocardia. But anyway, the case is still cool. So, so you see what is a single ventricle, and I'm going to maybe play this one at the same time. So there's one ventricle here, and then you had these outflows that kind of come out sort of swinging way over, which looks really abnormal, and then multiple things coming into the atrial chambers here. And on this view, and I'm sort of clipping these just the way that they came over to me, really. So there were side-by-side great vessels coming out of the heart. And here it is again, side-by-side great vessels with this big nub of muscle in between these two great vessels. So I wasn't sure which one was which, but they're both coming out together. And then by color, there is antegrade flow out both. So here you see the pulmonary veins. We've seen that before, coming back to the posterior. Now the marker's correct. So this is the left ventricle here, mitral valve. And then you see this really narrow, almost tunnel-like to the posterior vessel. And again, this huge infundibular tissue there between the two great vessels. And on the three-vessel view, this was super helpful. So it was really a two-vessel view, not a three-vessel. So SVC aorta is coming over the top to the left. And then as you scan down underneath, you see the branch PAs, and then you get this flash of red flow coming into the PA here. And that was actually some retrograde flow in the ductus to the PA. So the PA was posterior. Even though there was antegrade flow, there's not enough antegrade flow. And so, I don't know, maybe the 80th clip or something was this one. And so after all that time, I was like, oh, it's tricuspid atresia. I'm like, this is perfect for the talk. So plate-like tricuspid valve, normal mitral valve with good function, this real hypoplastic right ventricle, and that side-by-side great vessels with the conus, I think that this is double outlet right ventricle with tricuspid atresia, which I've never seen before, and I hate when I say that because I've been doing this for a long time. But I looked it up, and there's a few cases described in the literature. She's 20 weeks gestation, so we'll see for sure. But I think double outlet with transposition. So kind of excited to see how that evolves. So treatment for these patients. So it's a balance between the pulmonary and systemic circulation. So if you don't have enough pulmonary blood flow, then those patients need PGE, prostaglandin dependent, and then a BT shunt, typically after birth. If they're balanced, like I talked about, then maybe you can just watch them until 4 to 6 months before needing a bidirectional glen. If they have too much pulmonary blood flow, you may have to ban them. If they have transposition with a small VSD and that aorta is small, you might need to do an arch repair. You may even have to do something called the Damas-Case-Stanzel, where you combine those two vessels together so that any blood flow coming out of the heart will go to the body, and then do a BT shunt as well. And then type 3 is just variable depending on what you have. So untreated, these patients have high mortality, just like any other single ventricle, but surgical experience now for these patients is really, really good. So over 90% survival at 1 month and 80 plus at a year, and then it pretty much stays like that. So 10-year survival is also 80 plus. The patients who do poorly are premature, low birth weight, maybe need ECMO, or if they have some underlying genetic syndrome. But life expectancy is pretty long, and I tell families without a number, I say they're most likely going to outlive you, which I think is a good way, just a reference point to think about the difference between tricuspid atresia and what Dr. Turetsky talked about with hypoplast. So shifting gears, Ebstein's. So this was initially described in 1866 by Wilhelm Ebstein. It's adherence of the posterior and septal leaflets to the myocardium, and then redundancy or fenestration of the anterior superior leaflet. So this leaflet gets really redundant. We call it sail-like, and then the septal and posterior leaflet get plastered down to the ventricular septum. And because of that downward displacement, you have atrialization of the ventricle, making it look really big, and then the AV valve annulus gets really dilated, or the tricuspid valve annulus gets dilated. So this is really rare, 0.5% of all congenital heart disease, balance between male and female. Most cases are sporadic. It used to be, and early on in my training, it was, people felt this lithium was a problem for moms being on lithium, but a recent meta-analysis just a few months ago, looking at numerous studies, showed that that's not true. This is what they look like after birth, and I just thought this is such a good picture to give you a sense for how massively dilated the ventricles actually get. And really, all of this usually is the atrialized right ventricle and right atrium. So that happens because of significant or severe tricuspid regurgitation. You get right to left shunting at the atrial level, which makes them cyanotic, and their degree of cyanosis depends on their PVR. So sometimes after birth, as the PVR falls, they get less shunting right to left, and maybe they wouldn't be as cyanotic, but the big problem when the when the heart is this big is you get some compression of the lung as well. And so if you get lung underdevelopment on top of Ebstein's, these patients can do very poorly, and I'll show you that. This is a cartoon of sort of exactly what you look at. So the true annulus should be here, matching the mitral valve annular plane. And the right atrium gets dilated depending on how much tricuspid regurgitation you have. But it's this displacement here, greater than 8 millimeters per meter squared displacement, tells you or suggests that that's Ebstein's. That, coupled with the fact that both the septal leaflet and oftentimes the anterior leaflet are tethered or sort of stuck to the myocardium, is another hallmark. And then this portion here, the atrialized right ventricle, so everything below the annulus down to where the coaptation point is of the leaflets, is the atrialized right ventricle. And the combination of this area and this area, when it's bigger than the rest of the heart, is a very poor indicator. And that's a great Ormond Street score that has to do with that. So this is what it looks like on path. Again, dilated right atrium, atrialized right ventricle is really abnormal, but all these attachments of that valve to the underlying myocardium. So here's a first one. This one's kind of mild. You have some displacement from the annulus here down to about where the arrow is, and then you see some mild plus tricuspid regurgitation there. This one's a little bit more severe. So there's multiple attachments here sort of swinging all the way down, and then you have displacement along the septum down towards the apex. And this is the way that looks. It looks like the tricuspid valve is unguarded, or there's actually no valve there, but the valve is actually down here towards the apex. And sometimes even it's rotated up into the outflow tract. And so when you put color on, there's color that is shooting down towards the bottom of the ventricle, and it's because the whole mechanism of the valve is rotated up like this into the outflow, and so when the ventricle squeezes, it shoots blood down into the apex of the ventricle. That's how abnormal these can get. So here's another one. This one it shows you how, what I talked about, almost like a sail-like anterior leaflet, except this is really thickened and dysplastic. It doesn't look like a sail at all. It looks like a club or something that is trying to bang over against the ventricular septum, and you don't see any leaflet there at all. And that's what happens. You get just torrential amounts of tricuspid regurgitation, which results in this huge right atrium. And so your CT ratio here is like 75% or 80%. These patients do very poorly. Here's just sort of another look at that, this thick and dysplastic anterior leaflet, and you see attachments here that are sort of holding that septum from swinging all the way over, but you don't see anything moving from the septum. And again, this is what you get. Sort of, because the leaflets can't touch one another, then you get pretty significant tricuspid regurgitation, which results in that right heart dilation. Because the right atrium gets so big, these patients are also prone to supraventricular tachycardia, and we just got lucky. They went into tachycardia right while we were scanning. And so this picture shows supraventricular tachycardia in a patient with Ebstein's, and kind of converted on his own, obviously. So, and there you see the leakage down towards the apex of the right ventricle. Here's one more. Here's another one, big sail-like anterior leaflet, but nothing here at the typical annulus, and this displacement all the way down towards the apex. So here's that crux. This is right side. And then one more, again, sort of unguarded there. So it's important to add in these Ebstein's patients that sometimes they have so much going backwards or back into the right atrium that they don't have enough antegrade flow to open up the pulmonary valve. And so they develop a functional pulmonary atresia. And you can see that in this patient where the flow is coming from the ductus back towards the pulmonary valve, and even a little bit of pulmonary regurgitation confirmed here by Doppler. And patients who have PR in the setting of Ebstein's with a functional, basically no antegrade flow, those patients also do poorly. So a higher odds ratio of mortality. This is just showing that retrograde flow here, red in the ductus. There was a paper a few years ago, multi-center, looking at these, so 23 centers, 243 patients. The perinatal mortality was 45%. And of those, the patients that had the highest CT ratio, the biggest tricuspid valve annulus diameter, were the ones that didn't survive. So those are the patients that do the worst. But those deaths are also sprinkled all over the place. So these patients really don't do that great. So it can be really severe with high perinatal mortality, poor prognosis, the severe TR, the functional pulmonary atresia, resultant PR, the cardiomegaly with this increased ghost score, which is the atrialized right ventricle and right atrium bigger than the rest of the heart. If you have high drops, arrhythmia, and then lung hypoplasia. So briefly for tricuspid valve dysplasia, this I think is sort of like a cousin. I think about it as like a cousin to Ebstein's, and oftentimes is mistaken between the two. The main difference is that the tricuspid valve is in the normal position, and the leaflets here are typically thick and nodular or irregular, like at the tips, but you still can have significant regurgitation. So this is what that looks like, sort of thickened leaflet tips. This is not very common, so I don't have very many of these, but real thick leaflet tips, but it's at the annulus. And there's that same sort of significant tricuspid regurgitation. And here's another one. So again, the annulus looks normal, looks like sort of a normal four-chamber view, but you have a big right atrium, and then you can kind of see high drops here in the background. And I mean, without even playing this, you sort of see that the amount of regurgitation was massive, causing high drops. And you know, these patients won't do well if they develop high drops, but sometimes if they don't when they're born, when the PVR falls, they actually do really well, and we don't even have to operate on them. So that happens more often than not. Okay, so switching gears again, pulmonary atresia intact septum. So this is severe hypertrophy of the right ventricle, and the tricuspid valve has varying degrees of stenosis or narrowing in size, and that has shown to be almost a predictor of whether or not you can make these a two ventricular or one ventricular, or what we call a 1.5. The pulmonary arteries are almost always confluent, unlike pulmonary atresia ventricular septal defect. And then the kicker for these that was mentioned earlier is these sinusoids. And the reason for those sinusoids is that the right ventricle generates a high amount of pressure but doesn't have anywhere to go. And so it basically keeps these early coronary connections open or patent. So over the course of development, when the coronary arteries develop, these sinusoids go away. But if the pressure in the right ventricle is so high, it keeps those sinusoids open. And that's why after birth, if you decompress the right ventricle and they're dependent on those coronary connections, those patients can die like acutely in the cath lab. And I'll sort of briefly mention that again. So we talk about this in terms of unipartite, bipartite, and tripartite ventricles. So specifically what that means in this case is that you just have an inlet. So you see a tricuspid valve, there may or may not be a little bit of flow across it, but that's about it. The rest is just muscle bound. In a bipartite, you have an inlet portion and a little bit of a muscular portion. And then in a tripartite, you have the inlet, muscular, but also an outlet. So if you sweep up towards the pulmonary valve, there's still some cavity up there. And the way we break this down, and we sort of use this, is that if you have a tricuspid valve Z-score that's really small, so less than -5, those are unipartite ventricles. Those patients almost always have coronary sinusoids, and they move down a single ventricle path. This group over here, we'll call group C, those are the tripartite ventricles. Z-scores are bigger, so greater than -2.5. They oftentimes have tricuspid regurgitation. So if I see a pulmonary atresia patient that has tricuspid regurgitation, that's usually a good sign clinically that the ventricle has the potential to grow. And oftentimes these end up being two ventricle repairs. So they have membranous atresia that can be decompressed after birth, and the right ventricle will grow. The ones in the middle are sort of the crapshoot, -2.5 to -4.5, the bipartite ventricles. Sometimes they have sinusoids, sometimes they don't. Sometimes you can decompress them, sometimes you can't. And this is the group like Dr. Tretzky was talking about, where there's so much uncertainty that the parents sort of look at you like, how come you can't make up your mind? It's just a difficult group. So starting with what they look like, here's a four-chamber view. The tricuspid valve you can see, but the right ventricle is kind of small. It's almost apex forming, but in this case, you have quite a bit of TR. And so even though that RV looks small, I was like, oh man, this might be okay. But you have to do more than that four-chamber view. Unlike the tricuspid atresia where I kept saying you can see that plate-like tricuspid valve, for pulmonary atresia, I think the three-vessel view, arch views will really help you significantly. So this is showing that, I'm saying three-vessel, but I'm really showing you only two. So here's the aorta and SVC, and then again, as I sweep down, I see the branch PAs there, and this retrograde flow, again, from the ductus that's supplying the pulmonary arteries. So the two vessels are the SVC and the aorta, and then I scan down, I see branch PAs with retrograde flow. And so then you got to start thinking, absolutely, this is pulmonary atresia in text septum. So here's another one, really small right ventricle, good left ventricle, normal function. And then here's an RVOT shot that's similar to this cartoon here. So MPA, aorta, SVC, you have the branch PAs, but you have retrograde flow again from the ductus supplying the pulmonary arteries. And this is what that looks like from a sagittal arch cut. So here's a normal aorta, and then you have this ductus coming off the underside of the aorta, and it has this tortuous sort of course, and you'll have retrograde flow into your pulmonary arteries. So here's another one, really small right ventricle, kind of just looks muscle bound. I really don't see much of a tricuspid valve at all. And I look up and I see retrograde flow in that ductus supplying the PAs. Here's that same patient. So as I come up a little bit, you see these branch PAs are really small. And then here's that was that big circuitous ductus there. And then the PAs are kind of underneath that aorta over the top. Here's another one, real small, sort of muscle bound, almost looks like the hypoplast that Dr. Tresky was showing, but obviously this is anterior, posterior mitral valve looks good, left ventricle, right atrium looks terrible there. And this isn't, when we see something like this, we start looking for sinusoids, so you lower the Nyquist down significantly, you start picking up sort of color within the myocardium. That's not a great picture, but this is just to emphasize that when you lower that Nyquist down, you're looking for that color, and you see all this flow around, as well as this big one right here that has bidirectional flow right up towards the AV valve annulus. And this was the patient's cath after birth. So we inject it into the right ventricle, and the flow goes through the wall into this coronary network and comes up, travels up to the ascending aorta and fills the ascending aorta retrograde. So that's what I meant about those coronary sinusoids. And in these types of patients, if you have any narrowing, you have to leave those ventricles alone because that's the way they're perfusing their myocardium. This is what it looks like on path. These huge coronaries, and it goes right through the myocardium like this into the body of that right ventricle. So that's the fistulous communication there. So if you have a fistula present with no stenosis, you can decompress, and you will fill antegrade from the aorta coronary into the myocardium. But if you have any stenosis, you do not want to decompress them because the patients will die. So these patients actually don't do very well. If you shunt them alone, the mortality is almost 50% in that first group, the bipartite group. If you can open up their right ventricular outflow tract and provide another source of pulmonary blood flow, it's better, but it's still not great, so 70 to 80%. That was just one more reminder of these different groups. Tricuspid valve, so the four-chamber view may give you the diagnosis, but the outflow tracts will sort of complete the picture because you have to see whether or not those great vessels are transposed. For the pulmonary valve, I think the four-chamber is a start, but you really need the three-vessel view, outflow tract view, arch views to assess how blood flow is getting to the pulmonary arteries. Good luck.